Hi, I'm Dr. Sameena Syed. I'm an internal medicine physician with Hoag Medical Group. I practice at Fashion Island. And today I'm going to talk to you about cancer prevention and screening. So here's an outline of what I'm going to talk about. I'm going to talk about Hoag's structured support towards cancer care, the prevalence of cancer, the deaths, and then also risk factors and screening tests and options to look for cancer. So in terms of Hoag's structured approach, there's many things that their oncology services have to offer, and I'll touch further on the high-risk clinics in a bit. There are also Hoag cancer navigators that are able to connect with patients and help guide them through this journey. The clinicians do a team-based clinical approach with tumor boards, and there's also support groups that are available for the various types of cancer. So to start off, I want to kind of talk about what is the most prevalent type of cancer, what has the highest death rate. And I know it's kind of intimidating to think of cancer in this way, but it's also nice to know what's out there. So these charts are these graphs, charts are from the cancer registries. So looking back from 2014 to 2018, the highest incidence is with breast cancer. But you'll find that the death rates are number 2 from 2015 to 2019. And this is what the blue chart up in the corner is looking at. The green chart at the bottom is looking at the estimated new cases and deaths for 2022. So focusing back at that blue chart, I talked about how breast was number 1 and prostate is number 2, and then number 3 is lung and bronchus, followed by colorectal. And then looking at death rates, number 1 being lung and bronchus, and then breast, prostate, and colorectal. The green chart, significant change from the blue chart, is that colorectal cancer is estimated to be slightly higher than breast and prostate cancer. And even though that seems like it is relatively higher, if you'll notice, it isn't as many, possibly because of screening tests and also knowing different risk factors that cause these diseases and good preventative care at this point. So this is splitting up the number of deaths by leading cancer types and gender. So number 1 with lung and bronchus, you can see that there's a little bit more of a male predominance. And then for number 2 with colon and rectum, kind of evenly split between male, female. And then pancreatic and female breast, prostate. And these were in 2020 as opposed to the data in the last slide from the cancer registries, which was over 4 years. This is just 2020. And this next chart is kind of nice because it lays out how the rates have changed over the years. So the y-axis that kind of starts at 250 and goes down to 130, you'll notice doesn't necessarily start at 0, but it's kind of changed so that we can cleanly see the change over time. And you'll notice the bottom axis is between 1999 and 2000. So it's looking at a 20-year range of age-adjusted cancer death rates. And so cancer overall is the second leading cause of death in the United States. Number 1 is heart disease. And so what these colorful lines show is the blue is the total deaths, whereas the green at the top is looking at male and female is the orange. And so you can kind of see that they kind of have come down over the past 20 years and has come down 27%. And this is data from the Centers for Disease Control. And that kind of makes us wonder, well, what has helped change these cancer death rates over the years? And so there have been targeted public health prevention and cessation and also more knowledge of the risk factors overall. And I'll go into more detail on that soon. And there's some cancer vaccines that have been made available, like the Gardasil human papillomavirus vaccine and also hepatitis B. And then screening tests the guidelines have changed over the years, and I'll talk on that next as well. And new cancer treatments, it's amazing what has happened in oncological care in terms of personalizing treatments and being able to treat specifically what is happening with certain types of cancer and the biologics that have been able to personalize that care. And so with risk factors, things to consider are family history. So with that, your highest family history, I'm going to touch on this more later, but within family history, there's high-risk clinics and genetic testing, and then tobacco, obesity, and alcohol. So going a little deeper on family history, first-degree relatives diagnosed before age 50. This includes any adult children or any siblings and parents. Beyond that, your grandparents, your aunts, uncles, those are going to be other secondary relatives. And for that, it would be if you have 2 or more relatives on either side, whether it's paternal or female. And if you have that, then you're considered more of a high risk. And then also if you have a male relative with breast cancer. There are some ethnicities that tend to have a higher risk as well, which include Eastern European or Ashkenazi Jewish ancestry. And then there's also some hereditary syndromes like the BRCA genes for breast cancer, and then Lynch syndrome with gynecologic and colon cancers. And within this, I wanted to also highlight that we do have high-risk clinics at Hoag looking at ovarian cancers with Dr. Abaid, and we have Dr. Selby with pancreatic and hepatobiliary cancers. And we also have a high-risk breast clinic with Dr. McDonald. And then there's also the looking into genetic testing, and so we have genetic counseling available as well, where they can discuss whether to do genetic testing, and the testing can be done through blood or saliva tests to look at your DNA. Now, in terms of tobacco use, this is something that I think many are aware of, and it's more than just cigarette use. Even with using cigars and electric cigarettes, there's about 70 chemicals that can be found in cigarettes, cigars, pipes that can cause mutations and changes in your DNA that can potentially lead to cancer. And with the e-cigarettes, there's also the fact that there's a certain type of material that's used in it that has to create the mist that can also cause some changes in the DNA. So in terms of looking what type of cancers can be caused, a lot of it can be related to the local area that tobacco impacts. So the mouth, the throat, the voice box, the lungs, and then also the esophagus. And then it also impacts, with the lungs, impacts a lot of areas where blood flows, because the lungs kind of are able to have the exchange between oxygen and blood, and so wherever blood flows and wherever there's kind of detoxification, you'll find potential for cancer as well, with the liver, kidney, and then also acute myeloid leukemia, and then other cancers such as pancreatic, bladder, cervix, and the colon and rectum. Now, in terms of obesity, to pinpoint what obesity really is we're looking at the body mass index as a screening tool. And it's a ratio of your height and weight. And so BMI between 25 and 30 is considered overweight, and above 30 is considered obesity. About 42% of adults in America are considered to be obese within this metric. And so what you find with obesity is that there is long-lasting inflammation in the body. And so with this long-lasting inflammation, there's higher than normal levels of insulin-like growth factor, and sex hormones. And this gets to be an issue because then you have more inflammation that can lead to more issues with your DNA and more mutations that can have downstream effects. Now, the most common obesity-associated cancers after menopause, the highest for females is breast cancer, and then for men is colorectal cancer. So here are some cancers associated with being overweight and obese. And so this includes, like I mentioned, the breast cancer and also colon rectal cancer, also liver, gallbladder, your upper stomach, pancreas, kidneys, uterus, ovaries, multiple myeloma, your esophagus, and meningioma. And all of the figures that I'm presenting here are from the Centers for Disease Control and other cancer society websites. So alcohol use. In general, the less alcohol you drink, the lower your risk for cancer. And so the general recommendation is for adults of legal drinking age, for males to have 2 drinks or less in a day, and then 1 drink or less in a day for women. Now again, less is better. And this is because alcohol breaks down into a chemical called acetaldehyde. And so with this, you'll notice that this is also kind of the areas that are impacted the most are areas that are involved in the breakdown of alcohol, and detoxification, so the liver, your colon and rectum, and also your esophagus, your voice box, and your mouth, which are related directly through alcohol drinking. Now, in terms of vaccines that we have available that do prevent cancer, this includes the human papillomavirus, which is also known as Gardasil. There's been several commercials about it too. And so the age range for Gardasil is generally ages 9 through 26 and can also be up to age 45. And so this is generally, if it's done before ages 11 to 12, it is a 2-dose regimen. And then above that, it is a 3-dose regimen. And the human papillomavirus is something that can cause genital and oropharyngeal cancers and also anal cancer as well. And this is what is commonly associated with the cervical cancer screenings that females do to assess for cervical cancer. The hepatitis B vaccine is another vaccine that can also prevent liver cancer. And so this is available for all age groups. There's a variety of groups that would benefit the most from this, including healthcare providers, and if people are incarcerated, or if you're having a lot of sexual partners. So just ask your provider if you think that you would benefit from the hepatitis B vaccine. In terms of lung cancer screening tests, now I'm going into screening tests for different types of cancer. So lung cancer, from before we saw, had the highest amount of deaths. And so with lung cancer, the guideline is for a low-dose computed tomography scan. And so the idea being that with this low dose, you're not getting too much radiation. And it's recommended for people between ages 50 and 80 years old that have 20-pack year smoking history or more and have quit or have current tobacco use or quit within the past 15 years. This guideline has actually recently changed. It used to be ages 55 and now it's lowered to 50. And then in the past it was also 30-pack years instead of 20-pack years. And so tobacco use can increase your risk for lung cancer 15 to 30 times. Now in terms of colon cancer screening tests, this is something that used to be age 50 but has actually gone down to age 45. This is something new from the past 2 years. And so 45 to 75, and you can even go higher than that too. Now in terms of the start time, that is also based on certain criteria, like if somebody has inflammatory bowel disease, family history, or a genetic syndrome, then that age can change. And then risk factors for getting colon cancer include physical inactivity, having a diet low in fiber, low in fruits, vegetables, or high in processed meats. And then also alcohol and tobacco use also increases your risk for colon cancer. Now in terms of the types of screening tests, there's a wide variety of them. Now, if you're willing to get yearly screenings, there is the guaiac-based fecal occult blood test, which essentially tests for blood in your stool. And then there is also, in every 3 years, there's another option, which is the fecal immunochemical test, known as a FIT DNA. And so this is like the Cologuard that you've probably seen commercials about. And so with this, it tests for things in your stool that can lead to colon cancer. And so it kind of tests for the DNA in the stool rather than just testing for blood, which is in the yearly test. And that is done every 3 years. And then every 5 years, you can consider the virtual CT colonoscopy and flexible sigmoidoscopy. Now these have their own cons in that the CT colonoscopy, you can't act on it. You would have to, if there is something of a certain size, then you'd have to follow that up with a colonoscopy to be able to get a biopsy of it. And then the flexible sigmoidoscopy, while it's beneficial that you don't have to use anesthesia for it, it only allows a gastroenterologist to look into the first, or rather the last third of the colon. And then there's the colonoscopy, which can be done every 10 years. Now that varies based on what the result of the colonoscopy is. So it may be shorter, like every 5 years or 3 years, depending on other risk factors. Like if you have a family history, it could be every 5 years, or if you have inflammatory bowel disease, it could be different, or based on the findings of the colonoscopy. But in an ideal situation, you have a colonoscopy and you don't have to have another one for 10 years, and you have that clarity of knowing that everything has been looked at in your colon. And this is generally done under light sedation, depending on your situation. Now, in terms of breast cancer screening tests, this is different based on what society you look at in terms of the age range. So the American Society in terms of gynecology will say ages 40, as well as the American Cancer Society will say age 40, and then a frequency of 1 to 2 years. If you remember from before, breast cancer is something that has a high prevalence. It's found pretty often. So I think a lot of physicians would advise towards having pretty frequent breast cancer screenings. And you have a higher risk if you have dense breasts, if you're older in age, if you've had earlier periods or late menopause. The idea behind that being that there's more estrogen in your body. And then physical inactivity, hormone replacement therapy, which kind of also goes back to the idea of having more hormones in your body, and oral contraceptive use, and then also having your first pregnancy after 30, and alcohol use. It's actually been found that clinical and self-breast exams are not helpful. This is something that is also new over the past 5 years, and so with that, the finding was that with these breast exams in office, with self-breast exams at home, that it was a little bit more anxiety provoking and led to more screening tests that led to more biopsies that ended up not being anything of real significance. So if there is something like skin findings that a patient has, then certainly go see your medical provider to see if that should be further evaluated. If you feel like the lump is not moving well, if it's pretty stuck and then there's skin changing, like skin peel, orange peel above. And then if you're under age 30, the screening test for that would be an ultrasound. And then otherwise, the general screening test is a mammogram. And then if you're high risk, it would be a breast MRI. And based on your situation, you may get a mix of these studies. And then in terms of cervical cancer screening tests, we talked about this a little bit in terms of the human papillomavirus vaccine. So risk factors include not having the HPV vaccine, Gardasil, and then tobacco use, not using condoms, and multiple sexual partners also increase your risk. The guideline is to start at age 21, which is a change. It used to be as low as 18 or the start of sexual activity, but the standard now is age 21 and then every 3 years until you're 30. And then once you reach age 30, then it can even be stretched out to every 5 years with PAP and HPV co-testing. And now all of these numbers are based on not having an abnormal pap smear. If you've had an abnormal pap smear, then these ranges change. And then if you have routine screenings that are normal, then generally a patient can stop at age 65. Now in terms of prostate cancer screening tests, they're surprisingly no longer recommended. It was found that with prostate cancer screenings, in terms of the digital rectal exam with a finger to palpate or feel for any abnormalities in the rectum, that wasn't a good way of judging if there was abnormalities with the prostate. And then based on the PSA also was another option. So for ages 55 to 69 years old, it is a discussion between your provider whether you would like to get the PSA-based screening. Because, and this also goes back to the digital rectal exam and the PSA, if these are elevated, then these false positive results, these thoughts that maybe elevated prostate or maybe some findings on a rectal exam lead to a prostate biopsy, and the prostate biopsy can lead to complications that tended to be worse overall with incontinence, urinary incontinence, and also erectile dysfunction. So at this point with prostate cancer, the general way of looking at it is to see if a patient has symptoms, like if they have issues with urinating or issues with waking up at night to urinate often or a slow stream, then we would kind of make sure we go down the trail of trying to see if a patient could have prostate abnormalities. So in general, I wanted to touch on what the CDC also had in terms of what to do for screening for other cancers, and there just isn't great, there aren't great screenings for certain types of cancer, which include ovarian, pancreatic, prostate, testicular, and thyroid cancers. So with a lot of these types of cancers, it's going to be important to kind of be aware of your body, and if you notice things, go and see your physician as soon as you can. If you have vaginal bleeding, if you feel like you have a lot of abdominal pain, or you have lost your appetite, if you've had a lot of weight loss, if you notice something strange with how you're urinating, or if you have issues with swallowing in terms of thyroid cancers. And then also, so the USPSTF that I noted there on the second part is the United States Preventative Task Force that kind of creates a lot of the guidelines that we use in internal medicine and family medicine. And so they also found insufficient evidence to look at the risks and benefits of screening for bladder cancer, oral cancer, and also for skin cancer in terms of what age to start screening for skin cancer. In general, the advice that internal medicine, family medicine will say is kind of be on the lookout at your skin and see if you have any abnormal findings, and they can also walk you through the A, B, C, D, E's of melanoma, looking for asymmetry or irregular border or color changes, a strange diameter, or raised elevation. And that's all I really wanted to talk about for cancer screenings today. Are there any questions? Okay. So I'm glad that I was able to discuss this today. Cancer screening is very important, and being preventative about it will lead to hopefully better outcomes in the future. And I'm happy I was able to share that with you. Have a good night.